respectively of this group, and this group presented abdominal obesity. In 2016, the estimated prevalence at the national level was 75% and 69% in men. This reflects the magnitude of the changes and the health disease patterns of the Mexican population, secondary to the demographic dynamics, where the population grows trends in the age of groups 40 to 70 years. The maximum prevalence of overweight is seen in the groups of 30 to 39 and 60 to 69 years old, and obesity of 40 and 49 and 60 to 69 years for men and women, respectively. The prevalence reported in the epidemiological context of obesity characterized it's an emerging disease of epidemic proportions with multifactorial etiology, product of the interaction between the genetic composition of individuals and the environment that surrounds them. So, regarding the epidemiology of obesity, only the 5% of the cases are secondary to factors such as treatment with different drugs, specific endocrine disorders, or definite monogenic syndromes. The remaining 95% is lifestyle-related obesity, resulting from difference between energy intake and expenditure, the effect due to regulation of gene expression or polygenic variants, and or through the environment. Obesity, like I said before, is characterized by a state of excessive of adiposity, generalis or central, resulting for a positive energy balance maintained for a long time, the etiology of which involve environmental factors, genetic factors associated with various metabolic processes that influence both the regulation of ingestion and in energy efficiency and the deposit of energy reserves in adipose tissue. Sorry for this image. It's in Spanish. I hope there is no problem with that. So the physiopathology of obesity is mainly attributed to the expansion of white adipose tissue, in which adipocytes increase in number and size. This is called hyperplasia and hypertrophy, which generates an imbalance in body composition and dysfunctional white adipose tissue. In a clinical scenario with a predominance of obesogenic factors, I mean it, genetic and environmental, mainly the expression and interaction of genes related to energy metabolism in dysfunctional white adipose tissue, an inflammatory response of particularly response exclusive characteristics develops. Chronic low-grade subclinical inflammation secondary to the increase in adipogenesis, resulting from the migration of cells of the immune system, I mean from, from the blood circulation to the white adipose tissue, with a pro-inflammatory phenotype, generating a redundant pathogenic process, where the expression of pro-inflammatory cytokines and adipokines increases. For example, leptin, resistin, TNF-alpha, interleukin-6, and CCL2, among others. In body weight gain, adipogenesis is increased, while adipocytes increase and decrease in size in order to adapt to changes in lipid load, generating an accelerated rate of apoptosis and subsequent accumulation of macrophages for the tissue remodeling. This phenomenon is explained by a hypoperfusion in the supply of oxygen. This is called hypoxia, which favors an increase in apoptosis rate of the adipocytes and is associated with an increase in body weight. The number of M1 macrophages in adipose tissue and in serum levels of pro-inflammatory cytokines like TNF alpha and CCL2. The white adipose tissue is the anatomical target where these immunometabolic alterations associated with obesity develop. The mechanism suggested for this process are the increase in the number of M1 macrophages in the white adipose tissue, the levels of free fatty acids, this calls lipotoxicity, the ectopic deposition of lipids in tissues, I mean the distribution and location, and the levels of pro-inflammatory cytokines and adipokines and another secretion products of what? It's important to notice that the monocytes migration to adipose tissue is an early event in obesity-induced inflammation. Antagonistic regulation is through the activation of anti-inflammatory pathways that inhibits the M1 response. So cytokines and adipokines, anti-inflammatory cytokines, such adiponectin, favors metabolic regulation of the white adipose tissue, allowing the oxidation of fatty acids and revascularization of the tissue, which decreases the apoptosis rate by increasing the supplies of oxygen. In an obesogenic environment, by stimulation of pro-inflammatory cytokines like interferon gamma and lipopolysaccharides, polarized M1 macrophages that are subsequently activated and produce pro-inflammatory cytokines. This is called the classical pathway. But alternatively, in a physiological state, the monocytes that migrate towards white adipose tissue by stimulation of anti-inflammatory cytokines such interleukin-10 and arginases polarize M2 macrophages and produce anti-inflammatory cytokines like interleukin-4 and interleukin-13, among others. This is called the alternate pathway. In this way, the phenotype of macrophages confers on them a function in adipose tissue. M2 macrophages contribute to white adipose tissue homeostasis, while M1 macrophages, promote inflammation. So in obesity, M1 macrophages make up the 50 to 60% of the resident cells population on the white adipose tissue, participate in the maintenance of the chronic low-grade subclinical inflammatory process. Since they secrete pro-inflammatory cytokines, directly interfere with insulin signaling, giving rise to metabolic dysregulation and pathological adiposity. When white adipose tissue is metabolically dysfunctional, adipocytes necrosis increases and they become hypertrophic and hyperplastic, and M1 macrophages surround these cells, forming crown-like structures. Adipose tissue is an specialized connective tissue with a functional capacity for storing fat in the form of triglycerides. Its anatomical location could be dermal, subcutaneous, perineal, retroperitoneal. Its parenchyma is made of preadipocytes, adipocytes, tissue matrix, nervous tissue, vascular stromal cells, and cells of the immune system, which form an integral functional unit. Histologically, my favorite, it is classified into white adipose tissue, brown adipose tissue, and beige adipose tissue. They are different in the body proportion, amount of mitochondria, fatty acids, oxidation, coloration, morphology, body distribution, expression of genes, chronobiology and function, and it is distributed in different proportions throughout the body. The pattern of distribution is dependent on several factors, including sex, race, age, ethnicity, genotype, diet, physical activity, hormone levels, and medication. Brown adipose tissue has a multilocular adipocytes with abundant mitochondria that express high amounts of uncoupling protein 1, best known as UCP1, responsible for the thermogenic activity, while white adipose tissue is made of unicular adipocytes. Its main functions are store lipids in the form of triglycerides and for the production of leptin, control energy intake, and its distribution to other tissues in interdigestive periods. The importance of this fat storage function is weighted by the adverse metabolic consequences. The balance between brown adipose tissue and white adipose tissue changes in response to different factors such as cold, heat, and obviously obesity. The beige adipose tissue is an interface between brown adipose tissue and white adipose tissue, since its function as an energy stores and produce heat. This is the between of the both. The formation of the white adipose tissue begins before birth, although the chronology of the appearance varies from one species to another. In the human being, the greatest expansion of the same takes place quickly after birth and develops through life. The adult generates new adipocytes in response to high-calorie diets. The parenchyma of the adipose tissue is composed of different cellular lines, the pre-adipocyte and the adipocytes, and the cells of the vascular stroma. The vascular stroma is composed of endothelium and the cells of the immune systems. When adipose tissue increases, like I said, it is metabolically modified. As obesity develops, adiposity becomes hypertrophic. Macrophages in healthy adipose tissue express anti-inflammatory cytokines, whereas macrophages in obesity express pro-inflammatory cytokines. This is important, and it's a little complex, but there's many markers to evaluate inflammation in the tissue. And an early marker of inflammation is the erythrocyte sedimentation rate. This provides a measure of the acute phase response to disease with an inflammatory component and reflects the alteration in the protein composition of the plasma, whereby erythrocyte sedimentation increases due to an increase in the concentration to acute phase plasma proteins of a large molecular size. On the other hand, C-reactive protein is produced in the inflammatory process and binds to monocytes and neutrophils to promote epsonization and phagocytosis through complement activation directly and indirectly. And it also activates mononuclear cells, peripheral blood, with the subsequent release of inflammatory cytokines. In relation to adiposity, it has been observed that the inhibition of anti-inflammatory adipokines and its receptors inversely correlates with PCR, suggesting that the decrease of these anti-inflammatory adipokines contributes to vascular and systemic inflammation commonly found in obesity. The complement protein 3, known as C3, and its anaphylatoxin, C3A, are key mediators in decrease in adiposity since they favor the migration and activation of macrophages to what? Adipose tissue. Likewise, adipocytes, macrophages, and hepatocytes are an important source of C3. On the other hand, it has been suggested that the relationships reported between C3 and components of the metabolic syndrome could be the result of some metabolic action of the molecule or reflect a parallel production by adipocytes or macrophages and some another cytokines, such as TNF-alpha, interleukin-6, with metabolic effects. Likewise, complement protein 4, C4, has been associated with adipose tissue and the development of visceral adiposity. The visceral adiposity is known like the dangerous adiposity. Since the complement system responds to infection and inflammation and are considered as independent risk factors for the development of metabolic syndrome. In the presence of an obesogenic phenotype, these lipidemies can occur, consisting of increased levels of triglycerides, LDC, low density lipoprotein cholesterol, okay, LDLC, apolipoprotein B, and free fatty acids, as well as decreased levels of high density lipoprotein cholesterol, HDLC. The dysfunctional metabolism of lipids, oh my God, we have 113 participants. This is great. The dysfunctional metabolism of lipids occurs from its absorption, transport, and storage. Triglycerides are lipolyzed in the intestinal lumen into free fatty acids, and 2-monoacylglycerol cholesterol is absorbed by enterocytes and transformed into cholesterol esters, while free fatty acids and 2-monoacylglycerol are assembled into triglycerides again. Once transformed, cholesterol esters and triglycerides pack with proteins together with phospholipids to form chylomicrons. Chylomicrons are secreted into the lymphatic vessels and eventually enter to the circulation through the thoracic duct. The liver synthesizes triglyceride-rich lipoproteins called very low density lipoprotein cholesterol, called VLDLC. In reverse cholesterol transport, HDLC promotes cholesterol absorption from peripheral tissues, including the arterial wall, and returns the cholesterol to the liver. Enterocytes and hepatocytes synthesize apolipoprotein A1, which is the structural protein of HDLC. Nascent HDLC particles acquire free cholesterol from peripheral tissues, and subsequently, the cholesterol in HDLC is converted to HDLC esterified cholesterol associated with lecithin cholesterol acyltransferase. On the other hand, I'm not finished yet. It's also been described that small and dense LDLC particles called small, dense, low density lipoprotein cholesterol are highly atherogenic and have a higher affinity for arterial proteoglycans, resulting in a rotation of subendothelial lipoprotein and therefore greater damage to arterial tissue. Likewise, as a part of the indexes that predict atherogenic risk are three important: triglycerides, and the ratio to triglycerides and HDLC, total cholesterol with HDLC and LDLC with HDLC. This is the relationship. This is a ratio to correlate more atherogenic, okay? In lipoproteins, there are many fractions that are considered. Apolipoprotein A1 between the ratio apolipoprotein B1. Sorry, B, only B. So there are two sources of free fatty acids. First, the lipolysis of triglycerides-rich lipoproteins within the circulation. And second, the intracellular lipolysis in adipose tissue. So we know that when we talk about a pathological adiposity, we are talking about a dysfunctional adipose tissue. And this leads to insulin resistance. Insulin resistance, it's in a clinical state characterized by the decrease in the effectiveness of insulins to reduce blood glucose levels, and it occurs in myocytes, hepatocytes, and adipocytes that present an inability to respond to the metabolic action of endogenous insulin and require consuming 200 units or more of insulin per day to prevent hyperglycemia or acidosis and manifest itself in increased glucose levels in blood. An important note, in Mexico, the prevalence of insulin resistance has not been reported yet. However, with the prevalence of overweight in adults, I said it before, 73 and 69% in women and men respectively, and the type 2 diabetes mellitus in individuals from 60 to 60 years with 19 and 90.1 in women and men respectively. There is an ER prevalence reported estimated to 16 and to 25% in not diabetic population. But there is a report in Western Mexico of a prevalence of insulin resistance of 28.5%. Okay, so epidemiological data reported in other countries show different prevalence of insulin resistance. In the United States of America, in teenage populations, 52%, Ecuador, 38%, Iran, 28%, Madrid, 9%, while in Mexico, based on the findings for other populations and the results of the 2010 population and housing census, it is estimated, listen this, that 10 and 16 million people present insulin resistance, and of these, between 6,063 and 1 million are residents or Jalisco. Okay, the identification of individuals with insulin resistance is carried out with different criteria. The gold standard is the hyperinsulinic euglycemic clamp method. This was decided by Tronso in the 79. This method evaluates the sensitivity of the tissues to endogenous insulin for its development. Insulin is administered maintaining a concentration of 100 microunits per milliliter. Simultaneously, glucose is administered to maintain basal levels. Under these conditions of constant glycemia, the rate of glucose administered is equal to the glucose taken up by the cells in the body. Since the implementation of the hyperinsulin euglycemic clamp demands technical skills and is invasive, long-lasting, and high cost, other methods of insulin sensitivity resistance have been proposed. The other method is the proposed for Matthews and College in 85. It's called the insulin resistance homeostasis assessment model. This is a mathematical model. It's used to calculate this HOMA-ER that relates the serum glucose and insulin concentration. These have a 87% correlation with hyperinsulin euglycemic clamp. Stern, but other way, develop a model that integrates two criteria: body mass index plus HOMA-ER, with cutoff points for BMI greater than 27.5 kilograms per square meters and HOMA-ER higher than 3.6, classified in ER with a sensitivity of 84.9% and with a specificity of 78.7%. With this model, it is possible to cover the 90% of the area under the curve that is obtained with the hyperinsulinemic euglycemic clamp technique, the golden technique. By other hand, Galloso is another author, carry out a meta-analysis that includes the evaluation of the HOMA-ER and the components of this metabolic syndrome in diabetic and in not diabetic populations, in women and men in different age groups. In this study, cutoff points were established for the adult population for 2.05 and 2.07 in men and women, respectively, older than 50 years with diagnosis of insulin resistance, taking into account metabolic and cardiovascular disease. So this image is complicated, a little, not too much, okay? Okay, at the cellular level, I mean it, in adipocyte, hepatocyte, and myocytes, the binding of insulin to its receptors generates phosphorylation of insulin receptor substrates, which alternatively regulates signaling. If phosphorylations occurs in tyrosine residues are upregulated in construct. If phosphorylation occurs at serine residues, it is downregulated, okay? The insulin receptor is a glycoprotein made up of an extracellular alpha subunit and a transmembrane beta subunit. The binding of insulin to the alpha subunit results in the dimerization of the receptor to form the alpha-2 beta-2 complex in the cell membrane and the autophosphorylation of the beta subunit at tyrosine resides. This is the first step for the activation of the insulin receptor. Once active, tyrosine kinases phosphorylation transduce insulin signals via insulin receptor substrates, which they provide a specific binding site for the attraction of other downstream signaling proteins, leading to the activation of the MAPK and phosphatidylinositol 3 synase pathway directing cell differentiation. But on the other hand, phosphorylation of synases with serine resides modulate activity and expression of enzymes that block insulin functions such as glucose utilization, protein bonding, and future energy storage. The phosphorylation of serine synases is stimulated by, you can believe it, yes, by inflammatory pathways and involves cytokines such TNF-alpha, which leads to insufficient glucose uptake by muscle cells. However, its inhibition attenuates inflammation and improves sensitive to the insulin, a fact that has been demonstrated in rodents models and with patients with rheumatoid arthritis. On the other hand, there is a protein called COCS, This is involved in insulin resistance since they interfere with the phosphorylation of these receptors, orient these receptors for proteasomal degradation. So this is worse. So I don't want to bore you or something like that. So this is the conclusion of my presentation. In individuals with obesity, we see a characteristic dyslipidemia, a metabolic dysregulation. This is pathological. With subclinical inflammation, this can be explained because in the development of obesity, adipose tissue becomes permanently dysfunctional in the production of free fatty acids and adipokines, which have a critical role in the etiology of the metabolic complications associated with obesity. In this scenario, the evidence shows a complex biological relationship between the inflammatory immune response and the metabolism of glucose and lipids. And this conjunction, obesity, is associated with a chronic inflammatory response that is characterized by the abnormal production of soluble mediators by adipose tissue and the activation of several pro-inflammatory signaling pathways, resulting in the induction of different biological inflammatory markers. One example, chronic inflammation is associated with impaired glucose uptake by inhibition of insulin-stimulating lipolysis, in addition to the relationship between immune cells and metabolic organs. So this is all of my presentation. I hope you enjoyed it. I don't know if you have any questions.
Thank you very much for the presentation of Dr. Fernanda. And it is time for your questions. If you want to practice your English, you can do it with your open microphone, or you can write it in the chat, and I will do it for you to Dr. Fernanda. So don't be shy and ask your questions.
Don't worry, darlings. My English sounds terrible, so we can understand us.
Okay. Since somebody wants to make a question, I have a question for you, Fer. If you have to choose one therapeutic target for metabolic syndrome, which will it be?
Okay, depending of the what is the therapy, because this is a work that I planned in the past years. I mean, with the, epigenetic, there are many, the first problem is the diet, no? Okay, we can control the diet and we can have a control in a diet, but when the individual develops diabetes mellitus, it is not controllable. This is more far away of the control. So a good target is the pro-inflammatory cytokines, and not only for insulin resistance or not only for obesity. I mean, for autoimmune diseases, like CCR2, like CCL2, like TNF alpha, like chimerin, like resistin, like leptin, but we cannot, it's anti-ethical, knock down to a gene. We can do that. It's not ethical, but we should regulate the expression of the genes. So in this point, we can control it, not control it, because sounds like we are something like God, and we are not. We are simply humans, but I mean that we can modulate the expression of pro-inflammatory genes, so we can modulate the response, the immune response.
Thank you very much. I agree with you that the prevention of obesity and the prevention of insulin resistance is very important. And the environment factors like diet and exercise are very important for the control. And it is very well known that many factors from diet um, stimulates genes and regulate genes to make these epigenetic effects of obesity. In next webinars, we are going to have a webinar about epigenetics of obesity, so it will be very, very complementary with this webinar of today.
Smek Jair is asking what is anti-ethical. Where let me tell you something, darling. We need to follow protocols. After the World War II, we have protocols to follow, and this protocol, we need to be ethical with the use of with the humans, with the animals, with everything of tissues and cells, everything of the things we work. We can work with anything that we want. We need to follow directions and ethical and professional directions. Anti-ethical is you can do it because it's not good. In short words to say to you, it's anti-ethical to use a human as you like. You can do that.
Okay, I don't know if this question is clear, is responded for you, Jair, or if somebody have any other question, you can do it in the chat, or you can open your microphone and do it directly to Dr. Fernanda.
I have a question.
Okay.
I'll listen to you. Melanie.
Hi.
Hi, Melanie, my beautiful Melanie. I hear
My
you.
question to you is that given our current situation in Mexico of child obesity, the new labels on the food, you know, the ones that says like sodium excess or carbohydrate, do you think that they are doing something good, or that it's just like a waste of money?
Oh my God, that is a difficult question because we need to take a lot in count. Look, obviously we are a country with high percent of abdominal obesity, with obesity, with childhood obesity, and all these things. We know that the pandemic situation have a controversial part with our alimentation, no? So I don't know if it's good or if it's bad, but I know one thing for sure: we need to not change our culture or our I don't know our forms to be. I don't think so. But we need to control it because we have the highest percent in obesity in all the countries of the world. So Melanie, I think yes, in a part it's a waste of money. I think personally,
Yes.
because it's part of our culture. But we need to increment the education in all the people, because we are in this forum present are blessed with education, and we know how many is the danger for increment the calories or the body fat or not do exercise or something like that. But we know because we are educated, but there are many people in our country that are not educated, and
Yeah.
they simply do they don't know. So we we just can't justify it or something like that, because we are not in their places. We need to feel rules, yes, but we have culture, and we have food culture that is important to
Yeah.
us. We return to the desk only for eat,
Yes.
so we have a problem with that. Obviously, our problem, I think, personally, I think, is the basic education and the discipline,
Yeah.
but it's something that needs to be raised in all people, and that is difficult to do. That needs to be in the most poor population to the rich population, because all the Mexicans have a different ideas about how to do it or how to not, you know.
Yeah. Okay, thank you.
Thank
You're
you,
welcome,
Melanie.
darling.
Thank you, Melanie.
I have a question.
Yes, come on.
Um, First, good night. And with all this information, what is the most appropriate or recommended therapy to treat obesity?
Diet and exercise, because 90% of the population with obesity is for the lifestyle, but only the 50% is about the genes. Diet and exercise. I repeat, the problem is the prevalence in our country. We have many of our adults have diabetes mellitus. So we have a problem, because insulin resistance is a previous phase, is a preventable state, is not is pre type 2 diabetes mellitus. So when an individual develop diabetes mellitus, they had a higher problem, because that is not preventable, that is not reversible, that is a real damage in its pancreas. So what is the best treatment? The control, the mental control of you, diet and exercise, and be firmly with that.
Okay, thank you for Kenya for her
Okay,
question.
thank you.
Thank you,
Thank you,
Kenya.
Kenya. Is there any
Thank you,
other
teachers.
question?
Oh yeah, I would like to make a contribution about the opinion of Melanie. This new idea of the government that took a couple of weeks ago of place labels on the foods, on the junk foods. It's kind of a good idea, but also useless at the same time. Don't you think that? Because it's just like a warning, and the government doesn't have the responsibility to change the minds of the society. I would like to make a reference to the public health. I don't know how to say materia
I understand you,
assignment.
and I'm agree with you.
Yeah.
I'm totally agree with you. It's a little waste of money, because
Yeah.
our culture is multifactorial, and in one day to another day we can start to eat pozole or things like that, or gorditas or something like that. It's our culture, so you can put it to the high calories in our gorditas because it's our food. You
Yeah.
know it.
Absolutely.
So it's something about and I say it again, discipline, and oh my gosh, it's
Yeah.
discipline
It's
and
discipline.
culture and education, because we can still eating gorditas or pozole or menudo or birria, everything we like, but we need to control how much we eat. because
Yeah,
we go to the
self-control.
excess, you know?
Yeah,
We don't
yeah,
have a
absolutely.
media. We always go to the put out of coins, no? We're a little crazy with our food because it's delicious. I know.
Yeah, absolutely. And yeah, like you're saying in the chat, almost all of the people ignore those warnings because, well, there's more things, important things to do, like keep earning money. The problem is that the food needs to be fast and cheap. They don't see
Yes,
the
yes.
nutritional portions.
Because it's cheaper.
Yeah, yeah. All
Besides,
this lifestyle needs to be quick, and we don't have time to focus on what we eat and introduce into our bodies. All we need to do is to be alive.
Versal, I
Keep
know this
going.
is unusual, but I have a question. This is unusual
About
because I'm the
the
presenter,
labels.
but I
This
have
is
a
more like a
question.
public health issue because we need to focus first on the educations that you mentioned before.
Versal Osuna,
Yeah,
are you my alum? Are you my student?
yeah.
Okay, I have a question. This is initial because I know I am the presenter. I know. But what do you think about the people who didn't eat in a long hours? How calls that? In Spanish is
This horas, this tiempo.
I don't know. Is ayuno prolongado. What do you think about that? Because
Yeah,
it is interesting to me because a lot of people says that it's have benefits for the health, but it is not
absolutely not.
compromised. It's the fasting thing. I don't know. What do you think about that?
Well, about making stop eating in long periods of time, you make like a disorder in your metabolism because your body it's not receiving the proper nutrition and fats, vitamins, proteins. The body starts to generate fat that it's energy reserves.
What I mean, what is the moment when the biochemical routes, you know, starts? I mean, neoglucogenesis, gluconeogenesis. That where in what point this starts? In fact, we don't know. We know that we have a hungry and we are last hours and fasting. We don't know. Nevertheless, in some time, the nucleoneogenesis becomes okay. But when if you do this in very times in a week, in a month, what happens with the metabolism? This is regulates, the immune system participates, the nervous systems participates, because we know that the all cells in our body and our system, our body communicates and
With each other.
imagine what they say. They gonna say, this girl is crazy, is getting us with we are not getting fat, what we're gonna do, and something like that.
Yeah, it's like a domino effect. When something happens, it affects another thing, and that thing that it's affected by the previous one affects another thing. That's why that's where the diseases start coming, because
Yes.
the previous phase that you mentioned me before of the diabetes mellitus, it's the obesity. That's right. Obesity causes diabetes.
Of
And
course, of
of
course.
course,
Obesity causes insulin resistances and diabetes
exactly.
mellitus type
Yeah.
2.
And after
So
the diabetes,
you,
you develop new diseases. And yeah, like I said before, it's a domino effect.
yeah, of course, I'm agree with you.
Thank you.
Thank you too, Bersain.
Oh, you're welcome. I really enjoyed this conversation.
I hope so.
I hope that
And
my
I hope
opinion.
I didn't talk too fast because I get nervous and I'm starting to talk fast because I'm getting nervous. Sorry.
Oh yeah, don't worry, me too. It's not usual to me to speak English, but I previously worked on a call center, and it's like, the
Okay.
experience.
So that is easy for you because you talk with induce, and the idiom induce is talking is more difficult.
Yeah, it can be difficult to deal with.
It's more
English
difficult
people.
to understand. I'm sorry if I talk very fast, but I get nervous in the.
Don't worry. Yeah, me too. Sometimes when I get nervous, like right now, I start to talk real fast.
No, it's a spectacular,
Thank you very
and
much.
I like to share ideas with
Yeah,
all
me
the
too.
participants and answer different questions because we can imagine another
Yeah.
scenarios, you know?
Yeah, I completely understand, and that's part of the knowledge to change
Yeah,
ideas
totally.
with
Part of
other
the
with other
knowledge.
people. The dialogue, it's very important.
Yeah,
Yeah, I really
totally
appreciate your
agree.
time of listening me, and I really enjoyed your webinar. Thank you very
Thank
much.
you. Thank you.
Thank you, Versailles. And these webinars are for that, to practice your English and to lose the shyness that you could have about speaking English. We are not any of us is a natural and English speaker, but we have to practice to make it more natural. I'm going to read some commentaries from the chat. Jair says also, even if people know the food is not healthy, they are used to eat that food, so most of them will just ignore the advertisements. And also, Alexis Hernandez says, Doctora Fer, congratulations for your presentation and for being one of the best Kutonola teachers. Also, Dr. Miriam, congrats, excellent work from all people. Thank you, greetings and hugs. And also Daniela Sandoval says, congratulations, it was so interesting. I learned a lot. So if there are no any other commentaries or questions for Dr. Fernanda, I will thank very much her intervention of this webinar. Also, Dr. Laura Yareni says, congratulations for your great webinar. Thanks.
Thank you so much.
You
Thank
have
you. I was so nervous. You don't have an idea how nervous I was. Proud of being
proud of
your
being your
student.
student, Santiago.
I'm proud to be your teacher, darling.
Okay, and remember, we are going to have also 4 more webinars here to December. The next webinar is going to be Wednesday 25 at 7 p.m. The webinar, it will be cell therapy and hematopoietic stem cells transplant. For the professor will be Dr. Antonio Flores. So remember to connect to these webinars, and if you have 4 assistants to these webinars, you have a certificate from them. So thank you very much for all of us. Thank you, Dr. Fernanda, and good night for everybody.
Good night. It was my pleasure. Good night.
Thank you, teacher. Goodbye.
Thank
Good
you.
night. Good
Thank you.
presentation. Thank you.
Thank
Thank
you for
you.
being here.
Was an excellent presentation. Bye.
Thank you, darling. Bye.